the sick bay each month. They got to know that.
What were some of the signs and the symptoms, and how were these affecting you in your daily life?
I was having very heavy periods and very painful periods. But they would just talk about it. I would just hear like, by the way, okulumizibwa ngoli musonga si kirungi, but I would just leave it at that. And since like there was that opportunity of like maybe when I take painkillers, I get some relief. And by that time, maybe the pain was not very much extended, so I didn't over-concentrate on it until actually recently it had grown, like almost during COVID time.
For many women experiencing endometriosis, it usually takes a while to get a diagnosis. What was the journey leading to getting yours, and at the diagnosis, after the diagnosis, what were you told was happening inside of your body?
For me, going for a diagnosis, it was because my periods are regular. There is no day I've skipped. It came as a result of that unbearable pain that makes me not even to be able to do things the way others do, having to have a whole week off. Going to see a gynae, my interest was, maybe let me just tell them about the pain I have every month, because by that time it wasn't staying, it wasn't like remaining the way it is as of now. Yeah, because I think it has been progressing like that now. It is there daily, like even when I'm not in pills.
So when you went for a diagnosis, what tests did you go through? How did they get to find out what's really happening?
At first, I did a scan, ultrasound scan, and by that time, when I went, I was feeling pressed. Like each time I eat something, I want it out. So for me, I thought I was having malabsorption issues. So going, definitely anything to do with the stomach, they have to first do an ultrasound scan. So having done the ultrasound scan, they just told me, you have cysts. But they didn't explain the cysts, if they are where or where. So whatever they told me about the cysts, I was like, I didn't buy it. So it wasn't satisfactory. I just left it there. So for me, I was like, it was just like I told you, it was more of managing pain, not anything. So when they told me that, it was like I needed to have a second opinion. So out of seeking a second opinion, that's when I got another scan done by a friend who told me now, who tried to break it down and told me you have chocolate cysts. Oh. Yeah.
So Connie, please talk to me about how you manage this other pain outside of your period on a daily basis. Do you still have to take a lot of medicine, or is there an alternative?
The management kept on shifting from moderate painkiller like Panadol. Now it kept on, I started using ibuprofen, I went to like strong painkiller. Like say that at the moment as I'm talking, I have super exceeded most of the painkiller. That now if I take like a painkiller that I used to take back in the days when the pain was still moderate, it will not work. I will be like I've not taken. So at the moment, maybe injection, which sometimes I really feel like it's really not, it's not something I would want, but since it's the one which at least still, it is the one which is still giving me relief, I just take. But now you find like on a 5 days you are in period, you'll need to have 5 injections. So that kind of life, somehow there is a weight. Yeah.
What do you do on a daily basis when you feel pain?
On a daily basis, just like I always try to substitute with natural remedies. So being a food doctor, I try to work with food to reduce a lot of uptake of painkillers on daily basis. So I do more of clove water. And yeah, it has really been of help since like there are quite a number of medication I'm on, but for the pain, unless during periods when it's too unbearable, that's when I try to take, but not that daily painkiller.
Okay, so we have to use food as a medicine to avoid a lot of medication. All right, that's very good. So what's the next stage in this process? You said you have stage 4, you're at stage 4. So what's next for treatment?
At the moment, actually, stage 4 endometriosis, and I have both endo and adenomyosis. So it has advanced. Just like I said, I was supposed to have my surgery earlier this year, but I was unable to do it because of unavoidable circumstances and also resources, because just like I said, the disease has advanced. It would have been early if the surgery was done earlier. Before, I told you when I was first diagnosed, when I was told I had secret cyst, I didn't do much. I just left it hanging. So I think if I had done it by then, I think it was just stage 3.
Do you have any advice for young girls out there, especially in boarding school, as well as maybe their parents or their caregivers? How can they see the early signs, and what should they do in order to avoid this kind of case?
As a parent, if you're staying with a child, you will know when they are not fine. You will know when they are struggling. Because for this pain, even if you try to hide, someone will know. So when you get to know that this girl of yours is going through that pain, the earlier at least you try to seek health care, the better. Because all that time, like the way I've said, from when I started, it was really not, it was not bearable pain. You would see that I'm in pain, but parents would just be like, let me just get for you a painkiller. That's in that even they would just pack painkillers, but we're not seeking the required health care. So that one made the disease to progress, but in the name of using painkillers, but it's not being managed. So for me, early diagnosis is key. Then the other thing, silence about health care, like when it comes to reproductive health, sometimes it also makes things worse, because it really takes boldness to someone talk about how they are doing when it comes to their well-being, especially when it comes to something to do with periods. So sometimes some parents make it hard for their children even to tell them how they are feeling, and even when they start periods, maybe they don't want their parents to know. So it's you, the parent, to initiate this talk with that girl. Let them know that going in period is normal, and in case you are having this and this kind of signs, you can get helped. The earlier it's done, the better. And so that like we don't have that longer wait to have the disease treated, because the longer wait also comes with a cost implication. Because if you are to, by that time maybe I was going to be treated just like for 5 million, but now the disease has advanced, so I need like 30 million to sort the current issue. Yeah.
That is Connie Kwandit. If you're just joining us, she was sharing her story about her journey with endometriosis, a very, very severe, painful disease she's been dealing with for so many years, since the age of 13. And that is why we're here today, to understand what it is and how best we can. Sadly, we can't avoid it because we can't know how it comes about, but I just mean how we can manage it. So if you're just joining us, you are welcome. I am Viola Sasera. This is NTV Medical Matters. We are supported by Bill and Melinda Gates Foundation. And already in studio, we have an expert. That is Dr. Sematimba Stefan Kato. He is an advanced laparoscopic surgeon and endometriosis specialist at Crystal Medical Center. Sir, we are really happy to have you here today to understand what endometriosis is. So let's begin with that. What is it?
Thank you, Viola. Seeing that story of Connie is touching, so touching. But that is the typical story of patients in Uganda, or ladies, young ladies who go through severe menstrual pains and later becoming chronic pelvic pain. Unfortunately, most of these patients don't even know what's happening to their bodies. So it's, of course, a sad story, but hopefully, the more we talk about this, people will understand what exactly endometriosis is, how it's affecting their bodies, how they can know they have endometriosis, and ultimately we shall be winners. But endometriosis is that one chronic condition that involves tissues similar to what would be in the inner lining of the uterus. Those tissues migrate through mechanisms. They can migrate out of the uterus or the inner lining and the implant elsewhere out of the uterus. Now, most cases, these tissues, these cells they are live because they are being transported live. So the implant where they're not supposed to be, and it causes chronic inflammation. And chronic inflammation is the hallmark of endometriosis because these tissues are ectopic. They are not supposed to be where they are, and they usually affects first of all the nearby areas where the tubes are, because mostly they transport themselves from the uterus out of the tubes, and then the implant on the ovaries mostly. The rectum, the tubes also, they get affected. The uterosacral ligaments, the supports of the uterus. The nearby intestines, which is not necessarily rectum, but they can also be transported away. They can go to the nose. There's some people who, when they have periods, have nose bleeding. These tissues can be transported to, the body transports to the chest, and then people have difficulty in breathing during periods. So this is a debilitating condition that for long has been dismissed, and with more advancement in technology, with a lot of learning, and the doctors are getting interested in this disease, we have gotten to know that it's affecting at least 1 out of 10 women. Yes, you can imagine it. Like every 10 women you count, there's one person that is affected by endometriosis, meaning that about 190 million women in the world have endometriosis. Yes.
So you talked about the cells migrating, or the tissues. What causes that?
So, unfortunately, if we knew what causes, we'll be able to prevent this. But surprisingly, we don't know why. In some women, these cells are transferred out of the uterus. A similar condition called adenomyosis, they are cousin diseases. Connie talked about it. A cousin disease are the tissues. They leave the inner lining of the uterus where periods come from, or where the baby sits, and they invade the muscle of the uterus. So the uterus becomes very bulky. Okay. For the wrong reasons, women are treated for fibroids, just mild. They tell them you have menstrual pain, which is normal, and because this is something we don't know what brings it. It also brings a delay in most people who are not enthusiastic, I may say, or who don't take an interest in patient care are the people who don't take an interest in patient care. They dare to make a diagnosis. Oh, that was, you can see on the screen. That's how bad it can. That's the patient I was operating. That's how bad it can affect the system. So we don't know exactly what causes this disease, and we don't know who will get it and why a young girl of, for example, 10 years will start getting very severe menstrual pain, and after a few years they have endometriosis. So we don't know. But there are so many theories that try to explain, though they don't help us really, because if you know what causes the disease, you'll easily know how to prevent it.
Yeah.
Yes.
At what age would you say that it's most likely to start?
And there's not even a very specific age that we see this disease, but we commonly see this disease in women of reproductive age. I mean, as long as you start your menses. The youngest patient we have operated was 12 and a half going to 13. Can you imagine? With severe endometriosis, 12 and a half going to 13. This girl had stopped school because she couldn't bear the pain. And unfortunately, again, this girl was dismissed that this is normal until when she came to us and told us this is out of order. I can't bear myself. She had her suicide tendency. She was so depressed. She was almost committing suicide. This is a young girl of 12 and a half going to 13. So we see it commonly in women of reproductive age. You know, we see people who have not had children, people who have had children, people who are almost reaching menopause.
I actually almost asked you that, do you think there is a connection between the age, childbearing age, and the delay to have a child that would actually create its onset?
So the only issue about childbearing is when you, for example, you have children early bit, you have a break in your menses. When you have a break in your menses, there's no disease progress, or even if it's there, it's a bit low. I mean, so but there's no direct correlation between childbirth and who will get this disease. Recently, the last person I operated, she has 2 sets of twins and another. I mean, you can't really know who's going to get this disease.
For a second, I saw a glimmer of hope that perhaps if I continue having children non-stop, I'll have a break.
Yeah, of course. Yeah, you'll have a break.
But then you said before menopause, you got someone as well. Yeah,
surely. Even before menopause, as long as someone is having menses, they are at risk of having endometriosis. That's why we say when we start managing, we want to maybe sometimes stop the menses because it's the recipe for endometriosis. Yes.
So for a viewer watching, for any young woman that is watching or caretakers, what can they look out for? What are some of the symptoms, signs that may, give a clue that most likely you're going to have endometriosis?
Okay, what you're going to have. So it's that one is a bit easy. But the first things are usually when you have menses, you need to take painkillers. It's the first thing that shows you. Why? Why taking painkillers with menses? Because why are some people not taking painkillers and you're taking painkillers? It's one of the risk factor. I mean one of the telltale signs that something may not be right when you start taking painkillers for menses. Because a normal period is not supposed to be so painful. It's supposed to be having, of course we have some cramping, because the uterus is contracting to push out the blood. So we are supposed to, but when this cramping is so severe, it now raises alarm and isn't act. So one of the first signs of endometriosis is very bad menses. We call them bad menses. They are bad menses. It's one of the versatile signs. After that, so when you have bad menses, we have the medics have a duty to differentiate between what is it? Is it adenomyosis, endometriosis, or a combination of both? Because I told you, it's very easy to be a friend to your cousin, not so. So they are cousin diseases. So usually they can occur in the patient. Most cases actually they occur together. So apart from bad menses, we have our chronic pelvic pain. Most of our patients have our even after menses they continue to have pain. And when they grow and they start having intercourse, they have very painful sex, which is called dyspareunia. It's very painful. So you see these signs are almost close to everything is about pain. And the pain is around the pelvis. And so apart from dyspareunia, which is painful sex, they also have sometimes they have that feeling of nausea. That nauseating feeling. You want to, every time you are nauseating. Yeah, some people at first think, oh, they are pregnant. So they are nauseating because of the chronic inflammation. There's always something taking place, something boiling inside there. So these ladies also, and usually young ladies, like I told you, the commonest are young ladies, they have painful urination. That is dysuria. They have painful defecation. Apart from the painful, so it's usually about the pain of parts of the reproductive system and the nearby structures.
Okay.
Yes, but like I said, the commonest is the painful. When you have painful periods, you should come to the hospital. There's a reason as to why something is happening. So we should have a pain-free period. When you have chronic pelvic pain, it's not usually about infection. Most people are treated for infection, but it's not. Most cases it's not actually. Because even if you don't treat infections, the body will treat them and the body will heal. Okay. Most of these infections, the body combats them. And okay, it may leave damage, but it won't be painful. So again to the medical workers out there, when a woman tells you they have chronic pain, I think look beyond investigate beyond infections.
Okay.
Yes.
Let's talk about diagnosis. So Connie mentioned something about getting misdiagnosed. So what causes that? But also what else could be misdiagnosed, could be mistaken for endometriosis when you go for a diagnosis?
So the first thing I'll say is, of course, now when you look at Connie's story, I wish this story could be played as I think it should be, for healthy matters, this story should come out, like Connie's story should be on TV. Women should know that these things are real. They're happening. So there's a diagnostic delay, unfortunately. Most women take 7 to 10 years to know that they have endometriosis. And this is something we see every day. Someone comes to hospital and with clear symptoms, they are usually pain. And they have taken 10 years with this pain. And no one has ever told them that this is endometriosis. All they say is you have menstrual pain. Menstrual pain. So the delay takes long. If we could, first of all, combat the diagnostic as like I usually say, as medics, as health workers, we need to have a very high, low threshold. Like every time someone talks about pain during periods or bad pain during periods, your mind should run very fast. So usually they are young girls, 21. Why would you think about, for example, fibroids first in a young girl of 20 years because I mean it's unheard of almost. We have a few, but it's unheard of for a 20-year-old girl to have fibroids. It's not very common. So because of this delay, we find that most of these women come late with advanced disease. And you know, like a car which has been knocked and you are supposed to like knock, so there are cars you have a scratch on the road and you go and they spray and you go home. But there are cars which you have to leave your mechanic for a month or two. So sometimes you find this person that the disease has affected them so bad that most of the structures are affected, including the most vital organs of reproductive system, including the tubes. You can't have any tubes. You can't have ovaries are eaten. Sometimes they after surgery, these patients even go to menopause because the ovaries have been eaten up and you have nothing. So the diagnosis of endometriosis basically do a simple transvaginal scan.
Okay.
Now the thing is now again in the hands of a trained person.
Dr. Stefan, we are going to come back with that. We need to take a commercial break very fast. And when we return, dear viewers, I hope your questions are ready and that you'll be able to call and ask the doctor here whatever you might be going through. But for now, NTV Medical Matters goes for a quick break. Welcome back from that commercial break. If you're just joining us, it's NTV Medical Matters. We are supported by Bill and Melinda Gates Foundation. I am Viola Sasera. Today we are talking about endometriosis, which is a very painful experience. I have heard from the doctor 1 in 10 women go through, which is a huge number of people actually. So Dr. Stefan, we're going to continue with the diagnosis which is what we were talking about before we broke off. So diagnosis comes late, or someone is misdiagnosed. You talked about that, but then there is also what are some of the okay, so let me phrase it like this. When I arrive in the hospital and I tell you I have severe pain, what do you take me through to be able to establish this is what it is?
Okay, so like I told you, when you come to the hospital, I want to listen to your story. It's one thing listening to the story and one thing making out what the patient has. So when I listen to your story, I will know exactly. Because there are people who come, for example, with heavy menstrual bleeding as the honest sign. I mean, I would not think about endometriosis first. But now there are people who tell you, I have very painful intercourse and I've delayed to conceive. You know, of course, not every patient will come with painful periods, but some of them will say, I have very painful intercourse and I've delayed to conceive. So when you come to my office, for example, I'll ask you what I need to know, because I want to, whatever I want to, my brain is skewed to ruling out the worst case scenario. So I'll ask you a cocktail of so many questions, then I'll figure out. Unfortunately, there's no single blood test we do to rule out endometriosis. Not a single blood test. So, and that's what causes a delay. Most of these diseases, there are blood tests you can do to say, okay, this could be this.
Why is that? Why don't you have a blood test?
I think that is for the future. Of course, the rate of research is being done, and I think maybe in a few years' time, we shall come up with some of these biomarkers that are informative about who has endometriosis and who not. There's this sort of research taking place. And
do you actually have scans, and in a case where a scan is done, what do you usually find?
So the thing is, we do a transvaginal.
Okay.
Transvaginal scan. It's the gold standard. You ask me, what about the young girls of 12? So we shall reach there. But the young girls of 12, we can do transrectal.
Okay.
Through the rectum. It's a bit uncomfortable, but it will be very informative. So when we do a scan, for starters, with what we call a sliding sign, because normally your uterus is sliding, a woman's uterus is sliding. When you try to tap, uterus slides swiftly along the pelvic wall. So most cases, when we do a sliding sign, the uterus is not sliding. So yeah, of course now this is again for all those people trying to do transvaginal scans. It's for at our facility, it's a routine. All women who are having transvaginal scans, we slide the uterus. It's the first sign. Now, the other thing is, commonly, we see chocolate cysts. Now, this is one thing everyone can see. The sonographers, the doctors, they can see chocolate cysts. And now, when you are told you have chocolate cysts, now the community will now start knowing chocolate cysts is endometriosis, and usually that's advanced endometriosis. Most cases it's advanced because it means the ovaries are affected by endometriosis. Now, we usually give very many teachings about cysts, chocolate cysts, but this is not actually a cyst per se. It's blood. It's blood, actually, it's menstrual blood in the ovary. It's altered menstrual blood in the ovary. Can you imagine? Someone has altered menstrual blood. So it's, when we talk about cysts, a cyst has a layer which covers. But now this ovary this cyst is encased by ovarian tissue. That's why, again, now surgery becomes a bit tricky, especially women who have both sides. So you asked, what do we see? Commonly, we see a uterus that is not sliding. We see a fibrosis, like you see like some tissues are thickened around the uterus, around the uterosacros. They are very thickened. Sometimes you see a disease on the rectum. Very obvious. You slide and see. Then you see again enlarged ovaries. So those are some of the easiest telltale signs for people out there to know that you are told you have chocolate. Or when you have bilateral two sides, you wonder why a woman will have two cysts on left ovary, right ovary. They shouldn't be having. So it can be a telltale sign that something is going on. And when you try to, a normal transvaginal scan is not painful. When you try to do a scan, the woman is so tender. Like they are inadvertently resisting the scan. So you start saying this is a soft marker, or one of the first signs that why is someone resisting a scan.
For someone that has endometriosis or has all those complications you're talking about, how does this affect fertility? Because endometriosis causes chronic inflammation.
One, the first thing endometriosis will do, or adeno, because we merge them. When we talk about endometriosis, we're talking about adenomyosis. So when we talk about our fertility, endometriosis is going to affect the reproductive system. One, the tubes. They usually get blocked.
Oh, yeah.
Or they collect water, what we call hydrosalpinx. You find a very huge tube, which some people call, they call them cysts. They will have cysts, but when you find they are very big tubes, which are enlarged. So that usually those tubes are not functional. The ovaries, the ovaries are, this endometriosis reduces the ovarian reserve of a woman. So because women are born with a specific number of follicles, which are supposed to translate into how your reproductive capacity, because of this, the chronic fibrosis, the disease will affect the woman's ability to have, or to have the number of children they would have desired. Or these women reach actually menopause early because the ovarian reserve is so low. Of course, not everyone, but some of them. It's reduced a bit because of the ovary is undergoing chronic inflammation. The chronic inflammation affects the ovaries directly. Now, when you have adenomyosis again, now this is a cousin disease. We usually talk about them concurrently. The uterus is very tender, very painful, and its ability to have an embryo implanting there reduces because the blood supply is compromised. So you have a set of, we call it hypoxia in the uterus. Because of the hypoxia is one of what causes actually, again, the very painful periods. Again, now, the implantation will be difficult, so conceiving will be difficult. So remember, things now are attached together. They are attached. There's scarring, chronic scarring. So things are attached together. The tubes are not moving. Ovaries are stuck. Or uterus is stuck. So even if it's a tube is not affected, sometimes it can't move to pick an egg. So inadvertently causing infertility.
Okay, I understand there is no cure. However, how can endometriosis be managed? What are available treatments today, especially in Uganda?
So endometriosis is, of course, when you say no cure, you are going to scare people. What disturbs us mostly is the late stage. It's what is a bit, when someone say you have stage 4, of course, we no longer use stages. Stage 4, we use what we call the Enzian classification. It's a very good way of classifying the people depending on their compartments. So when you say, when you come to the hospital, we shall stage the disease. And we shall, the clinician will make a clinical acumen and will decide on how to treat. Most cases, when we are in early stage, we can manage medical.
Okay.
Yes, we can do medical, and because this disease is very dependent upon hormones of reproduction, sometimes we suppress these hormones. We give you pills, we give you injections, which suppress these hormones, so that we don't have someone continuously having menses, or even if their menses is just spotting. Sometimes we allow the spotting because it means the blood is not dropping back, and then we are suppressing the inflammation. So we also use painkillers, because the first thing that people come to hospital is pain. So we need to first manage the pain, and then if we see that the medical can't be of great help for you, then ultimately the gold standard will be we do what we call laparoscopy. It's usually advanced. We do advanced laparoscopic surgery to sort out most of this mess that has been caused by endometriosis. So, and usually these are very long surgeries. It's because we do a very meticulous dissection to separate what has been brought together. So we have to separate the scars. We do millimeter by millimeter dissection to separate the scarring, so that we call it unraveling the frozen pelvis. Usually frozen. What we see is the frozen pelvis. The picture that people are seeing, or the videos, women of everything is attached together. So we take time, do meticulous laparoscopic dissection to separate. Now the challenge sometimes comes because most cases people are operated for cysts. Because a cyst is a very good way of saying it as operated. Someone has pain, very chronic pelvic pain, very severe pain, they have a cyst, they go in. So most cases we find people have been operated more than twice, and these are wrong surgeries.
Oh my goodness.
Yes, and of course you can't blame the medical practitioner sometimes. Of course, now that we are telling people what is happening, they will know, and we shall have, at a point we shall start telling them that no, you have been doing the wrong surgeries. When someone has endometriosis, there is no room, there is no room for open surgery. This is a disease of laparoscopic surgery. There's no room at all, because your finger is too big that it can't separate these adhesions. You can't. So we do advise we do advise the health workers. You refer to a place where this patient can be managed, because the commonest thing is people enter for cysts, then you find a frozen pelvis, and then they close. So these patients go through a lot of back and forth surgeries, and the problem is they are the wrong surgeries, because you can't operate a patient of endometriosis before staging them. You need to first do a scan to stage the disease so that someone can have appropriate care, appropriate surgical management.
I just wanted to remind our viewers that phone lines are open. You can please call in and let us know what are some of your concerns. What have you had so far that you would want clarity on? The doctor is still here, so our phone lines are open. So let's move forward now to the surgery. How much does it rescue of the situation, especially when you're like at Connie's state?
The most unfortunate bit about these surgeries is, first of all, they are a bit expensive. And realize most Ugandans need support from family. They need support from everyone who cares to understand what they are going through, because these patients have gone through a lot, actually. Most cases, by the time someone needs surgery, they have gone through a lot of pain, a lot of distress, a lot of mental. I mean, it affects the brain, it affects your work. Most people are not working. So by the time they need surgery, they have spent a lot of their resources. Some of them have even lost jobs because you are supposed to have a show right now. You can't come because you're in pain. And the pain is excruciating that everyone will know. For example, you're on TV and everyone knows that you're in pain. So by the time these patients need surgery, by the time they are diagnosed, sometimes it's late. That's the unfortunate bit about this disease. They tell me, because the community dismisses, that's the first thing. The community dismisses menstrual pain. They'll tell them, you will be fine. Even me, I had menstrual pain, but it healed when I conceived. You will be fine. So by the time, the time someone we diagnose this disease, it's late, and the surgery is a bit expensive. Now, most cases, the first thing is want to make sure this patient doesn't have pain, because yeah, we are restoring the anatomy and all these things, but what brings these patients mostly is pain, and of course sometimes delay to conceive. So when we unravel the frozen pelvis, we want to make sure we resect every part that has fibrosis, because it's this fibrosis that causes pain. I don't know how to call it the simplest way, but there's a thickening. There's something thickened around. So the cells drop somewhere, they start thickening. So it's this fibrosis. So we separate everything. Now, when we unravel this pelvis, we are happy as medics. Of course, this surgeries don't come without complications, because it's a long surgery, it's a stressing surgery. The rectum is involved, the tubes are involved, uterus is involved. So you can imagine what you're seeing on the set. The rectum is attached to the uterus, everything is together. So because you're dissecting meter by meter, it becomes long. But at the end of the day, we shall be happy we have unraveled the pelvis. Now, we don't also leave without making sure we haven't managed the adenomyosis. Because even if you unravel and the patient doesn't have chronic pelvic pain, the adenomyosis, the condition I told you, the cousin disease, which affects the uterus, we have also to debulk the uterus to make sure this patient doesn't have, again, very painful periods as a result of unraveling the pelvis, but not working on the uterus itself. So the surgery is usually long, very stressful, but and that's what makes it a bit expensive. And what you need to manage this disease is also a bit pricey. So that's why some patients have decided, I mean, not decision per se, but they rather be on painkillers because they can't afford the care. And that's why that's when government should come in hand, actually, to help these patients a bit. I mean, it's just subsidize the surgeries and also train as many doctors as possible. This training is not mostly here in Uganda, so you have to transport yourself out of the country and leave your workstation and go and learn how to
I'm curious,
this
doctor,
disease.
Once this excruciating surgery is done, what do I need to do to make sure that I keep the disease at bay? So
again, usually most cases it's about your reproductive desires. So we shall, of course, after the surgery, we are happy we have unraveled the pelvis. We shall tell you we shall discuss with you, because what brings this is periods. So we need to first keep the periods down again. Now, because this happens over years, it's not one period that is going to give you endometriosis. It's not one period. It happens over years. So we advise, would you want to have children? You don't have to have children for now. If you don't have to have children for now, as a matter of fact, we shall give you some drugs to prevent periods until when you are ready to have children. Now, when you're ready to have children, again, you come back to us. It has to be sometimes we help. We help you in a cycle, increase the fertility rate in the cycle, and then when we increase the fertility rate, probably you conceive. If you don't conceive, we try again. Again, if you conceive well and if you don't conceive, we advise, please. If the best way is to do IVF, you go for IVF. Because actually most of our patients, actually 50% of our patients end up in IVF. Actually more than 50% of our patients end up in IVF. Because they come in late stage and this has affected almost all structures around. So if you're lucky to still have your eggs okay, we advise to have IVF and then to salvage your reproductive capabilities.
We haven't known the cause yet, but I'm curious, what lifestyle changes do you think could be done outside of the medical, procedures you talked about that can actually assist a woman, maybe have better reproductive health and maybe avoid endometriosis?
So most cases we advise on, for one, of course there are so many things. The first thing is nutrition. The first thing is when we find out that you have endometriosis, we put you in a support group. We have so many support groups. One of them is one of the most vibrant and active groups called Endometriosis Foundation in Uganda. So it's that we have so many young girls who are in the foundation that are helping to support others to live a pain-free life, sometimes without surgery. So when you have support, when you know that you are not alone, it helps you manage you. Or when you know that someone has done this to manage their disease, it helps. So the support is really very important. You also involve your family, because family is very important. Most cases, it's what you remain with when everyone has said they can't handle your absentia from work, they can't handle your absentia from school. It's your family which has to understand that this is not just mere menstrual pain, it's bad menstrual pain, and it's affecting you in a way that it's only you can tell exactly. So involve your family to make sure and support you. And again, we advise on your food. So there's a lot of feeding that increases, especially inflammation in the body. The oily foods, they are actually, it's what is appetizing to eat, but they increase, they don't help the inflammation that is happening. So when you increase for example, your omega-3 in the body, there are so many foods which have omega-3, the less oxidant, we have less oxidant supplements that try to reduce the inflammation in your body. And we advise on things like yoga, these activities that because there's a lot of mental health also. So we advise on doing these activities that relax your body. Swimming is one of them also. Massage, body massage, it relaxes your body, and then sometimes it takes away the mind from this debilitating condition. And when we involve everyone, when we feed well, when we do exercise, of course moderate, not very severe. When you exercise your body moderately, and then we give you a bit of painkillers that are not very dangerous to you. Because there are some painkillers, again, which causes addiction. Because most of these people who are addicted to painkillers, you have had people who have been taken to rehabilitation centers. Yeah. Many actually are because of severe pelvic pain. Many women actually, sometimes people judge these people, but these women are going through a lot of pain, and they're taken to rehabilitation, and sometimes they are mad. Some people think they are mad, but it's because of pain. So when we involve everyone around, when this lady is supported, and usually a young lady, when this young lady is supported, it makes the management much easier.
Dr. Kato, it's really a very, very interesting conversation. I've actually had things I never imagined were possible, and obviously the videos are evident enough to show how horrible, that's what I can call it, endometriosis can be. But I'm going to give you a chance to say your last words and your last remarks to our dear viewers as we head out. We have run out of our time.
Thank you, Viola. Usually I encourage young ladies to communicate with their bodies, as a matter of fact. if you have not been having menstrual pain, and when it comes, don't just take it for granted. Please go to the hospital for a checkup. Do routine checkups. Trust your gyne, and whenever you have doubt, please seek a second opinion. It's always good to seek a second opinion. There are so many women who have been dismissed, and their doctors have told them everything is okay, but for them, they're not okay. So have a second opinion, and we know there are so many. We are training so many people to be able to manage this disease, because these surgeries are long, it's debilitating. We are training so many people. So the ladies out there, we are there to support you. And there are so many groups, including the Endometriosis Foundation Uganda, that is supporting these women with endometriosis. And when you want to contact me, my number is 0775 92 98 90. It's my WhatsApp number, so you can 0775 92 98 90. You can always chat, and maybe you can have a second opinion and forge a way forward for our young ladies out there.
All right, thank you so much, Dr. Kato Stefan. It's really been a pleasure having you here. Thank you for sparing your time to educate our dear viewers about endometriosis. We hope to hear from you again. And dear viewers, thank you very much for sparing time to watch and educate yourselves about your bodies, especially the young ladies out there. And we didn't get the calls, but we hope that you can continue and follow this conversation on social media at NTV Uganda. And if you missed, in case you were busy, you can watch on YouTube as well. Thank you so much once again, and I wish you a very lovely week.